Hi, this lecture is going to cover the diagnostic techniques used when examining patients who have strabismus. When patients present with strabismus, often parts of the history are important to help make the diagnosis. Time of onset can be important if this is congenital or does it happen after an injury. Is the eye turn intermittent or is it constant? When the patient complains of diplopia, is it monocular or binocular? Is diplopia horizontal, vertical, or torsional? Is the strabismus or diplopia worse at distance or near or in a certain gaze position? Does the patient adopt an anomalous head position to get their eyes straight? And is there any prior amblyopia therapy or surgery or prism wear? A few areas of the examination bear special attention. An ability-appropriate vision is important to see if there's any sign of amblyopia or sensory causes of this strabismus. Sensory testing with the Worth 4-dot, stereo, and looking for anomalous retinal correspondence in older patients is important as well. Looking at any head position, nystagmus with null points. Looking at the lids, the slump, and the funness are important. Looking again for sensory causes of strabismus. And then a good cycloplegia refraction to see if there's any accommodative component to strabismus is also important. We'll be looking at a number of photos in the subsequent slides, but a detailed motility analysis is helpful as well. When I look at ocular rotations, I'm looking at binocular versions, both eyes moving together. And if there's any limitation in the versions, I'll do monocular adductions, covering one eye to see how the fellow eye moves alone. When I'm looking at the adducted eye, I'm looking for over elevation, which is a signifier for inferior oblique overaction, or over depression in the adduction, which is a sign of superior oblique overaction. When I'm looking at abduction, I'm seeing if there's any limitation, like 6 nerve palsies or thyroid eye disease. When I look for a limitation of elevation, I'm considering floor fractures or thyroid eye disease. You can also do special tests like saccadic velocity to see if a limitation of rotation is due to paresis or restriction, and doing forced sections in the operating room is often helpful for restricted disease as well. This is my shorthand notation for signifying overaction or underaction of specific muscles. You'll see this in my charts. Some doctors will also do an asterisk instead, but it signifies the same thing. Note that the abbreviations are not included in the chart. Notice also that the oblique muscles, the inferior oblique and superior oblique, act mostly in adduction, whereas the rectus muscles act primarily in, the vertical rectus muscles act mostly in abduction. Here's a patient looking to her right. You'll notice that the left eye has a moderate over elevation. We signify this as a +2 in the area representing the left inferior oblique. This patient also has over elevation of the left inferior oblique, slightly more than the prior patient, so we'll notice that this as a +3. The neuro-ophthalmology services patients are described as rotations by millimeters or percentages, so it's slightly different than the pediatric notation. This boy is looking up and to his left and has some limitation to elevation in adduction of his right eye. This patient has a Brown syndrome. You'll notice that the eye goes slightly past the horizontal midline, so this is a -3. The scale is plus or minus 1 to 4 for all of these overactions and underactions. This patient has a third nerve palsy on the left and is attempting gaze to the right. You'll notice that the left eye does not get to midline, so he's a -4 in adduction of his left eye. This patient had a traumatic right 6 nerve palsy after a motor vehicle accident and had subsequent surgery. Her residual deficit into right gaze shows some limitation of abduction of the right eye. We'll call this a -3. And also because of a large recession of her left main rectus, she has some limitation of adduction of her left eye. This allowed her to have single vision primary gaze. This gentleman had a left floor fracture after trauma, and you'll notice that the right eye elevates normally and the left eye has some limitation to elevation. We'll call this a -2 for elevation of the left eye. There are a number of methods of measuring ocular alignment, and you should be familiar with all of these. Light reflex testing, shown here, includes Hirschberg testing and Krimsky testing. These are good for kids who have a short attention span or who have poor fixation. The top two pictures here show Hirschberg testing, where we observe how far the corneal light reflex is displaced from the center of the cornea and can approximate a deviation based on this. The bottom two pictures note Krimsky testing, where you're using a prism to replace that corneal reflex in the center of the cornea. So this patient has a large exotropia, and with a 50 prism diopter base in prism, you're able to center the light reflex in that right eye, right over the center of the pupil. Here are two photographs where we're using corneal light reflex to estimate the degree of eye turn. In the top photograph, the left eye is fixing, and the corneal reflex in the right eye is just at the edge of the pupil. We'll say this is about an esotropia, about 30 prism diopters. In the bottom photograph, the right eye is fixing, left eye is turned out and is in the mid-iris, so we'll call this 45 to 60 prism diopters. As you gain more experience, you'll be able to better estimate these. Cover testing can determine the presence of a manifest tropia in patients with small deviations. In patient A, you are unsure whether the eyes are turned or not. In slide B, you're covering up the left eye and there's no shift to the right eye. This still leaves the option that the left eye is turned. In slide C, we see when you cover the right eye, there's no turn with the left eye. So patient B and C has orthotropia. In patient D, when you cover the left eye, the right eye moves outward to retake up fixation, so this patient is esotropic. In slide E, the right eye turns in with covering the left eye, and this patient is exotropic. In patient F, with covering the left eye, the right eye shifts down, so this patient has a right hypertropia. And in slide G, the patient has a refixation movement upwards when covering the left eye, so this is a right hypotropia, which you'll recall is the same as a left hypertropia. Here's a patient with what appears to be a large angle exotropia in the top slide, and just to confirm that this patient is truly exotropic, when covering the right eye, the left eye shifts in to take up fixation. So this cover testing is showing a manifest exotropia of the left eye. So here's a quiz question from your reading to think about. Which of the following tests demonstrates the presence of aphoria? A, the cover test, B, the cover-uncover test, C, Krimsky test, D, alternate prism and cover test, or E, simultaneous prism and cover test. Pause here, think of your answer, and we'll discuss on the next slide. So the cover-uncover test determines the presence of aphoria. Most patients have some latent misalignment of their eyes, so this test will bring that out. The idea is that you break up fusion by placing a cover, then you take the cover away to see if there's any fusional movement of the eyes. So the top two slides, A and B, take the cover away from the right and left eyes. There's no movement. So this patient is orthophoric. In slide C, when you take the cover away from the left eye, there's a refixation movement outwards to have a fusion, and this is an esophoria. In slides D, E, and F, you have also movements in for an exophoria, down for a left hyperphoria, and up for a left hypophoria. So these are all tests demonstrating the presence of aphoria. The next quiz question for your reading is, which test does not allow the quantification of atropia? This may be a little bit tricky. A, Krimsky test, B, Hirschberg test, C, alternate prism and cover test, or D, simultaneous prism and cover test. Pause to think about it and determine your answer. The prism and cover tests are a more accurate way to measure deviations than corneal reflex light testing like Krimsky and Hirschberg. So they're able to quantitate the deviation. And simultaneous prism cover test measures the tropia only, whereas the alternate prism and cover test measures the tropia and the phoria. I tend to do the APCT test in the office because that's the surgical angle I'm going to want to take care of. So let's walk you through an alternate prism cover test here. In slide A, the right eye is deviated inwards, and with covering the left eye, the eye shifts out. This is demonstrating the presence of an esotropia. When you switch the cover over to the right eye, the left eye then swings out. when we're guessing how much deviation there is, we're going to guess a 25 prism diopter prism, and we're going to put this base out in front of the right eye. We swing the cover back and forth, we see that it has undercorrected the deviation in slide D. The eye is still shifting out. We then can increase that prism to a 30 and switch the prism back and forth. When there's no movement, when the right eye is refixating in slide F, we note that as our answer. So this patient has an esotropia of 30 prism diopters demonstrated by the alternate prism and cover test. Here is another quiz question for you from your reading. Which of the following allows quantification of torsion? A. Red glass testing, B. Wirth-Ford dot testing, C. Double max rod testing, or D. Indirect ophthalmoscopy. So far we've been able to measure horizontal and also vertical deviations with light reflex testing and prism testing. Quantifying a torsional movement of the eye requires double max rod testing. And here you have a patient with trial frames with a red max rod in front of the right eye and a white max rod in front of the left eye, and you'll have the patient or yourself turn these rods until the beams are either seen as vertical or horizontal. And this will be able to quantify the torsion for you. When we have cyclovertical muscle paresis, we can do a test called the three-step test, and here's a practice problem for you. Which of the following is consistent with an acute right fourth nerve palsy? A. Right hypertropia, worse in left gaze and worse with right head tilt. Left hypertropia, worse in right gaze and with left head tilt. Right hypertropia, worse in right gaze and right tilt. Or right hypertropia, worse in right gaze and left tilt. If you have some fun, pick out which muscle paresis all these answers are for. Take some time with this slide. The three-step test is a way to isolate acute cyclovertical palsies. If the process is chronic or if it's a restriction, the three-step test does not apply. So let's go through briefly. In step one, you see which eye is sitting high. So in this case, the patient's right eye is high, therefore either the depressors of the right eye or the elevators of the left eye are paretic. Step two involves determining which gaze side the hypertropia is worse. This patient has a right hypertropia and seems worse in left gaze. Therefore, either the right superior oblique is paretic or the left superior oblique, because these are both the cyclovertical muscles that are acting in left gaze. The final step is looking at which head tilt has the more deviation. So in this step 3, the patient has a worse deviation with a right head tilt, which isolates it to a right superior oblique being paretic. Again, take some time to work through this because it's going to be very important for patients and testing. There are a few other tests that you can employ for specific problems in the office. Saccadic velocity can be used to look for floating saccades with muscle paresis. Force suction testing can be done to look at limitations due to restrictions. You can do a diplopia free field, so you put the patient in a Goldman visual field with both eyes open and determine what area they have single vision versus double vision. And lastly, AC to A ratio can be useful in patients who have esotropias. Okay, we'll wrap things up with a review of the 4 questions we had embedded within the lecture here. The first is, which of the following demonstrates the presence of aphoria? A. Cover test, B. Cover uncover test, C. Krimsky test, D. Alternate prism cover test, or E. Simultaneous prism cover test. So again, pause, pick your answer, and I'll be back in a second. Demonstrating the presence of aphoria is the cover uncover test, where you break up fusion with the cover, take it away, and see a refixation fusional movement. Second question, which test does not allow the quantification of atropia? A. Krimsky test, B. Hirschberg test, C. Alternate prism cover test, or D. Simultaneous prism cover test. So again, pause and come back in a second. So the answer is C. The alternate prism cover test measures the atropia and the aphoria, whereas A, B, and D all measure just the presence of atropia. Third question, which of the following allows quantification of torsion? A. Red glass test, B. Wirth-Ford dot, C. Double max rod testing, or D. Indirect ophthalmoscopy. Go ahead and pause. The correct answer is C. Double max rod testing allows you to quantify torsion. Indirect ophthalmoscopy can allow you to detect torsion, but doesn't allow you to measure it unless you have a protractor in front of your lens,